Good morning, good afternoon, good evening, ladies and gentlemen. I'm Oliver Cornely, University of Cologne in Germany, and will present today on the management of invasive mold disease. And that is comprising Aspergillus as well as mucormycosis. And not spoiling, but some patients have both. Here is my conflicts of interest. And the different aspects of managing invasive mold disease I brought in a chronological order. So imagine there is a new patient with AML, ALL, or suitable for allogenic stem cell transplant, for example. And what we nowadays do is a baseline CT. Upon diagnosis of the risk factor, which is leukemia and the neutropenia, we run a CT scan. The reason is this study, and there are now more studies, but we can see that if there is something abnormal on the lung scan upon diagnosis of leukemia, then there is a double risk of invasive fungal infection. So we can scrutinize on the patient. The type of infiltrate we might find can be anything. So it could be diverse as these 5 different panels on this CT scan. That is why I say Aspergillus is a chameleon. You see the infiltrate, it might be a more or less typical or atypical infiltrate, but you can never say this is or is not aspergillosis. For that, we need more diagnostics. And that means with any infiltrate, we would always do a CT scan. No, we have done a CT scan already if we did a baseline. If we don't do baseline, then persistent fever would lead to triggering a CT scan. And the diagnostic procedure that would follow is a bronchoalveolar lavage. That is the important aspect. And as soon as we did a BAL, we will hopefully send the material to all these pathogen analyses that are given in the middle panel. So if we follow all the different 3 paths, that one is looking at the host and identifying the host at risk, maybe even with typical symptoms. Number 2 is the clinical on the right side, which encompasses the imaging and the CT scan as well. And then in the middle, we do have the galactomannan index because we need microbiology. And microbiology might come from the BAL or from a serum sample where we find an antigen of Aspergillus, and that might be galactomannan because that is the one that has been most evaluated. When we have all 3, then we have a probable invasive pulmonary aspergillosis. Now we want to treat this, but before we do, we need to think about several aspects. One is drug-drug interactions. Is the patient receiving prophylaxis? Is the patient being treated with certain anti-leukemic drugs that might interact with prophylactic or with treatment chosen drugs? Usually that would be azoles they have a broad spectrum of interactions. And this paper I just mentioned because it has about 20 or 25 different drugs, and you can see what is the evidence and how do I handle my azole in these patients. Midostaurin is a drug with interactions with posaconazole, for example. So if a patient is on posa prophylaxis, then you need to, or receiving posa for treatment reasons, you need to take into account that posa will increase the midostaurin levels. What one usually does is posaconazole full dose and midostaurin 50% dose. And that would then lead to suitable, appropriate exposures of 2 drugs. But what can happen is that there is a clinical threat because posaconazole treatment or prophylaxis, you will stop earlier than midostaurin because that runs through all the way to allogenic stem cell transplant. So we need to be alert whenever we start or stop an interacting drug, that we do the right thing and do not underdose the patient. And very similar that is for venetoclax, but there we have a clinical trial that helps us. We know from this pharmacokinetic study from Agarwal that we can reduce or should reduce venetoclax to 25 or even to 12.5% of the original dose. Usually it would be 25% that venetoclax is being reduced to. Posaconazole stays with 100%. Again, when we start or stop one of these drugs, then we need to think about what will happen with the other drug in terms of exposure and drug concentration on our target structures. Okay, having all that in mind, now in patients who were not receiving prophylaxis, we are free to choose because we don't fear azole resistance, for example. So we are free to choose, and we can choose basically between isavuconazole or voriconazole. Voriconazole is the classic and the standard, and that is why isavuconazole was compared to the standard. And there was no difference in efficacy, as you can see from the survival curves. There were differences for some organ systems in terms of adverse events, so toxicity was less with isavuconazole in skin and subcutaneous disorders, hepatic and eye disorders. And since these numbers are a bit difficult to comprehend, so one doesn't feel what it means, I calculated the numbers needed to treat. And precisely, we have to say the numbers needed to harm for these three organ systems. So what can I avoid in terms of organ toxicity when I replace voriconazole, the standard, with the new isavuconazole? And I can avoid a liver toxicity every 14 patients and eye and skin toxicity every 9 and 11 patients, which is really low numbers. So it's worth it considering moving from voriconazole to isavuconazole. We did. More things to consider when choosing between the two drugs. Voriconazole needs therapeutic drug concentration measurement, TDM. If we don't do TDM, then we are flying blind with our voriconazole level. The target range where vori, if we use it, should be in is between 1 and 5.5. We even in prophylaxis would actually do TDM, but today managing infection, it's already there, so it's beyond prophylaxis. It's easier though with isavuconazole because there is no recommendation for TDM in treatment, or a C recommendation, C3, which is really weak, and it only says that there is mild recommendation to do TDM, but it's only expert consensus, while for voriconazole we know that we must do it. So that led already a few years ago, basically in the moment where the drug or where the paper was published on isavuconazole that I shared the results with you, led to this recommendation in Europe and basically all parts of the world that there is an A1 recommendation, so a strong recommendation based on randomized evidence to go for isavuconazole or voriconazole. And that is why we do have two that are recommended with the same strength, but isavuconazole, less toxic, easier to handle, less drug-drug interactions, etc. All that we summarized in an equal Aspergillus score, and we did so in many languages, and I'm happy to be able to share with you this one, and I can only read UV-Text 2b and Blanco 4, but you will be able to read it all. So we have the most important recommendations on this Aspergillus score, and whenever you fulfill one of the right side in the blue boxes, one of these suggestions, from prophylaxis to a diagnosis and treatment, then and follow up, then actually you earn, so to say, the score points right next to it. And if you build a sum of all the score points, then you can quantify what your adherence to the guideline is. Actually a nice tool, and for Candida we have done the same, and it has been published all over that that guideline adherence correlates with survival of the patients, and maybe that is the case with Aspergillus too. But that is not the end of the story, because there is the other fungus, the other family of all the fungi that cause mucormycosis. So let's have a look. Whether we diagnose Aspergillus, can we then forget about mucor, or do we think about mucor as well? So we should not forget about mucor, because there might be patients who have two intertwined issues, two problems. And this patient, a young guy, a little bit above 20 years, I met because I was asked to see him because he had this CT scan that was triggered by a persistent fever, FUO, fever of unknown origin, for more than 72 hours. And I came to the ward and heard of the patient, and I went in basically to say hello. I knew he was well taken care of by the team on the ward, but I was curious to meet the patient. So I entered the room, and the patient said, "Oh, doctor, great that you come. Could you please close the curtains? It's so bright in here." And he was receiving voriconazole. So I immediately knew, okay, that is another one with that drastically increased light perceptiveness, not liking it because it's really annoying. And it was a sunny day, but it was not at all so bright that one would close the curtains. One would actually open the curtains and enjoy the sun. He couldn't, because he was on voriconazole. So I transitioned him to isavuconazole. And on isavuconazole, he did well. And that was over a weekend. So the BAL was a bit delayed and was then done. The results came with a negative galactomannan in the BAL. And I thought, oh, that's interesting, because with these two relatively large infiltrates, I thought that it would be positive. So it was negative. Then we received the PCR results a bit later, 2 days, 3 days later, and we found Aspergillus fumigatus, or our colleagues from microbiology did so, and Rhizopus. So both problems, Aspergillus and a mucormycosis pathogen. And on day 7, we did another CT, because that is what we do as per guidance. Every week a CT, if there is an infiltrate, you want to know how it behaves. And the neutrophils came back, thankfully. On day 14, another CT scan, the neutrophils and the drugs did their job. So we have infiltrates that are decreasing in size, which is wonderful, good news. Despite persistence of blasts, that's always impressive, and was achieved here with the use of isavuconazole. So does it exist in your region, so to say, as well, in your part of the world? And I found data from South Korea, where there is Aspergillus co-infection improve mucormycosis. This is from the Asan Medical Center, if I remember correctly. They have massive numbers. Oh yes, I have it on the slide. They have massive numbers. It's a big, big center. So it's comparable likely to the size of quite some of the hematology units and centers in your country. And so they went back and did the last 67 proven mucormycosis cases, and then analyzed whether they had Aspergillus too. And they found Aspergillus in quite a number. So a third had Aspergillus as well, and maybe even more. So it's good to choose a drug that covers both. Even if you diagnose only one, you want to cover both. So let's have a look what that means for the choice of drugs, because I mean, it's a very short list of drugs out there that we can use for mucormycosis. It's basically only amphotericin B, and then we need so much that it is toxic, regardless of which formulation it comes in, ideally liposomal amphotericin B. And then we do have posaconazole is active, and isavuconazole, and that's it, right? So it's a very short list, and 2 are azoles. So it's actually only 2 classes that we can use. we did a matched control comparison where we matched cases patients who received isavuconazole in the program of the developer back then. And we did a matched comparison with amphotericin recipients from the Fungiscope database you may have heard of. And these were hematological patients mostly, and we matched them by risk factors. And we saw that the survival was not different between isavuconazole and amphotericin B. So that is what led to licensing of isavuconazole, was one part of leading to licensing of isavuconazole for mucormycosis. And I know that there is experience with isavuconazole, and even a study where that was where these two were compared, isavuconazole, amphotericin B, deoxycholate, so the more toxic original version of amphotericin B. And this is real world experience from China for primary treatment of mucormycosis. 47 isavuconazole treated, 59 amphotericin B treated. So that is a lot of patients for a mucormycosis study. It's one of the largest studies and publications out there. And the results, to summarize, is, of course, amphotericin B was more toxic. We know that, renal disorders, hypokalemia. And the salvage treatment was less often needed with isavuconazole. And in all these comparison, failure rates were, of course, less. That's similar to the treatment, salvage treatment rates. And but for all-cause mortality or attributable mortality, there was no significant difference. There was quite a number of patients were transitioned to salvage treatment, and salvage means basically, well, I said what's there. So one would salvage a amphotericin B patient, of course, with isavuconazole these days. Apart from mixed infections, and I already moved over to mucormycosis with the Chinese study, so there is in mucormycosis, I want to emphasize we need to do our CT scans every week if there is an infiltrate. It's CT scans then without contrast, and we can do low-dose CT scans, which is more or less the same as a chest X-ray, but it has much more information. So in this patient with 3 CT scans, on day 1, we didn't understand what was happening because that looks funny and it was beyond interpretation for us back then. Then the second panel, it already has that outer rim, which is called the inverse halo sign, but it's very discrete. It's not massive. So we still didn't understand. We said, okay, it's a funny infiltrate. And on day 8, it's still a funny infiltrate. It's a little bit bigger. Day 15, catastrophic. And now we have a inverse halo sign, which is really massive, as big as the chest, or that half of the chest. And we see the necrotic material in the middle. So if we, on day 15, we were then understanding what was happening, went back to day 8, and it was already there, and went back to day 1, and now when we see such a funny infiltrate, we go for BAL, of course, and we are really suspicious that it might be mucormycosis, and do everything on day 2 and 3 to really diagnose mucor. Because we don't want to run into such day 15 imaging, which is terrible. And if you have a delay in starting treatment of only 6 days from the first symptom, this was a delay of 18 days, I guess, here. Persistent fever, CT scan, is 3 days plus 15. So if you have a delay before you understand what's happening and treat mucormycosis, a delay of 6 days in hematology doubles the death rate from 45 to 90%. So almost everybody dies. Another intriguing image that I want to share with you is the so-called transdiaphragmatic mucormycosis. It has been described first by Philipp Köhler from my group here in Cologne in 2020. And we, by now, have seen 4 patients. 3 are in the publication. I have recently seen another one. So if you treat mucormycosis occasionally or have treated it rather often at your site, it would be really interesting that you go back and check the CT scans with mucormycosis in the lung and just scrutinize outside of a lung window, in a soft tissue window, to see whether there is involvement through the diaphragm, whether there's transdiaphragmatic mucormycosis, because it has never been described except from Cologne, and it's highly unlikely that it only exists here in Cologne. So it might have been overlooked at other places, and it's scientifically worth, and for the future, to always check the abdomen as well. One last of my cases that I want to share with you is a patient with AML, good prognosis, but then during neutropenia, a massive pneumonia. You see all the CT scans done weekly for good reasons, I guess you agree. And what we can see here on day 0 is just multiple nodules, and then they are cavitating on week 1. But when we saw these, and when we saw right next to the heart, patient right side, ventral, that is an inverse halo sign, right? And so we jumped in with liposomal amphotericin B, 10 milligrams per kilogram, 10. So there's no way to go higher, I guess. The kidney function was unremarkable, but after 2 days, the creatinine went up. So we had to reduce to 8 milligrams because we did not want to cause renal insufficiency, as renal insufficiency is an independent prognostic factor, a negative prognostic factor for patients undergoing stem cell transplant. And this patient was scheduled to undergo allogeneic stem cell transplant for the leukemia relapse and recurrence risk. So we had to reduce it down to 8, and then week 2 down to 5. We never go below 5 because below 5 it is not active against mucor. There are quite good data, and it's what the current guideline tells us. Then 3, 4, 5 weeks, then we started isavuconazole because we really had to stop liposomal amphotericin B, or we started it in week 2 or even earlier already. But we didn't dare to go monotherapy with isavuconazole. Only after week 6 we said, okay, now we stop liposomal ampho and we see whether monotherapy does the job. And it did. As you can see, it's improving, it's less aggressive, technically it's stable. We are waiting for the neutrophils. The patient, as soon as there were neutrophils and the patient bone marrow recovered, and he had halfway normal numbers in platelets and white cells and neutrophils specifically, he underwent surgical resection, because all what we did from day 0 to week 8 was empirical treatment. We were not able, despite bronchoscopy, to prove what was going on. We were just treating that CT image, so to say. And I was very happy after 9 weeks to finally get that result, that I was not wrong, but that it was Rhizomucor pusillus, and we did everything right. And this patient is up and alive after allogeneic transplant these days. It's about 2 years ago that we treated him, 2-3 years, I'd say. So, starting to summarize, we do have surgical debridement on the top of our algorithm for mucormycosis. But the patient I just shared is one of the many patients where surgical debridement is not possible at the beginning, only later during the course. If there is no renal impairment, then we treat with liposomal amphotericin at this high dose. If we do see severe adverse effects, we may reduce, as you saw, in steps, 8, 6, 5 or so, right? And just answering to mostly it's creatinine or GFR. And if we reach stable disease, we replace it. That's what we did in the patient. We reached stable disease by around week 6 or so, and then replaced it with isavuconazole monotherapy. We could have chosen posaconazole, but actually, why should I? Isavuconazole is licensed for it, so that's both are okay, but isavuconazole is the choice that we would go for. And remember, you need a loading dose, but I will come back to dosing on my last slide. And And then there are other variations here. It's if it's extensive disease, we can combine. That is what we did in the patient with the multiple CT scans, right? We combined as soon as we understood what was happening. And as soon as we understood that we cannot give 10 milligrams for 2 weeks or so, but only for 2 days before his renal function deteriorated. And that was really extensive disease, so we combined. If there is renal impairment, then it's much easier. You just jump down to the last box and treat with isavuconazole or posaconazole as an alternative if at hand, but isavuconazole is the one where there is more data now. So that is what we do in Cologne. We did an equal score with the same principles, and you can follow the score, and I hope the QR code leads you there. Otherwise, just Google or whatever, do a web search, and you will find it, or drop me an email. So we did that equal score for mucormycosis as well, and highly recommended is the weekly CT scans, low dose and without contrast. So on the treatment side, we have a very short list of drugs that we can use. For aspergillosis, certainly the first choice is either isavuconazole or voriconazole. For us, it's isavuconazole, and for the majority of centers likely throughout Europe, I would say it's ISA. Sometimes because of pricing issues, there is a discussion, but isavuconazole to me simply is the better drug. And there are multiple reasons. I mentioned these: drug-drug interactions, less toxicity, and much easier to handle, no TDM, etc. So it is efficacy-wise similar to voriconazole, but in handling and in toxicity, it's the better choice. We need to do the trough level with voriconazole. I'm not going to read the doses. They are here with the loading dose, etc. Then for mucormycosis, we have liposomal amphotericin B once per day. As we all know, this is given, and it's 5 to 10, or I would rather want to say 10 to 5 milligrams per kilogram per day. And then we do have isavuconazole as a choice for mucormycosis. It's the only one that covers Aspergillus and mucor and does not bring the toxicity of amphotericin. So in mucormycosis, it's now one of my favorite drugs, and likely I treat mucormycosis in some patients where I only diagnose aspergillosis, but both problems are intertwined, both are there. And we don't know in the end unless we do all the diagnostics, and even then there is a dark number. Well, that is my last slide, and I'd like to thank you very, very much.